Hello, thank you for joining us tonight for our BraceLab webinar tonight. Tonight we have WriStable being presented, a simple solution to a complex problem with Judy Colditz, occupational therapist, licensed certified hand therapist, and fellow of American Occupational Therapy Association. Don't forget to check out our upcoming webinars. We have pain pharmacology for the hand therapy providers, sustaining scope, elevating practice on June 25th at 8 p.m. Practice-related resources for hand and upper extremity specialists, key elements to developing and operating a private practice, part 1 on July 9th at 8 p.m. Rehabilitation of the overhead athlete, a kinetic chain approach, part 1 on August 6th, 8 p.m. A practical approach to treating the triumphant triad, harnessing the biomechanical linkage of the cervical thoracic spine and scapula to maximize upper extremity outcomes on September 10th, 8 p.m. Artificial intelligence and rehab, a game changer or a threat for hand therapy practice, and that's coming on October 8th at 8 p.m. And pain neuroscience education for the hand therapist, November 5th at 8 p.m. Are you an ASHT member? Don't miss out on the great opportunities that we have being an ASHT member. You have an annual subscription to the Quarterly Journal of Hand Therapy, a $235 registration discount to the ASHT annual meeting this year in Salt Lake City, Utah, October 22nd through the 25th. Discounts on continuing education webinar series, free continuing ed units each month by participating in the Journal Club and Upper Extremity Institute. Discounts on ASHT Career Center postings, online bookstore discounts up to $376, complimentary listing in the Find a Therapist public membership directory, and we're offering a group membership program and two-year memberships. Also, please take a look at our 2025 hand therapy review course for a comprehensive review of evaluation and intervention for typical diagnoses of upper extremity rehab. We've got one in Atlanta, Georgia coming up, August 15th through 17th. Baltimore, Maryland, September 19th through 21st. For more information and a list of new courses as they become available, visit asht.org education courses for more information. We also have our 2025 hands-on orthotics courses, Improve Your Skills. You could take these courses in St. Louis, Missouri, July 12th. Overland Park, Kansas, August 9th, Norfolk, Virginia, September 6th, Houston, Texas, September 27th through 28th, and Washington, D.C. on October 4th. Again, for more information, check out the asht.org education website. Just some housekeeping. Please close any additional programs on your computer to prevent delays and technical difficulties. If you're having difficulty with audio or video quality, please check the internet bandwidth in your home. If others are using streaming programs, this may slow down your connection, affecting this webinar's video and audio quality. Interact with the presenters. Make this your experience. Use the question box to answer your questions, at any time. And Q&A time starts after the presentation. Post-webinar, you will get a link emailed to you within 5 to 7 business days with access to the recorded webinar and quiz. If you have not received the email within 7 business days, please check your spam folder. Certificates will be available to print immediately upon successful completion of the quiz. Any reproduction of content is seriously prohibited. This is the property of the presenter and may not be produced without permission. And now, our guest speaker tonight, Judy Colditz. Judy brings her passion for simplifying complex topics to this webinar as she introduces the WriStable, an innovative wrist brace of her own design. Throughout her distinguished career, Judy has authored numerous clinical articles, book chapters, and research papers, and taught many courses and lectures across the U.S. and internationally. A 3-time recipient of the American Society of Hand Therapists Best Clinical Paper Award, Judy has served as president of both ASHT and the International Federation of Societies for Hand Therapy. As she retires from leadership ownership at BraceLab, Judy leaves behind a valuable collection of clinical resources for hand therapists, accessible through bracelab.com, Clinicians Classroom. So we are looking forward to Judy speaking tonight, and I will just get her up and running. Sorry for the technical difficulties. Got it.
Hello, everyone. Thanks so much for joining us. I understand there are quite a number of individuals who've registered for this, and I hope it'll be fun to learn about something new and different, the WriStable. I do see this as a very simple solution to a complex problem that frustrates all of us. Our support is provided by BraceLab, and BraceLab is the exclusive distributor of Push sports and Push braces within the United States. We also now, I say we, I am no longer the responsible person at BraceLab. It's under new ownership. But BraceLab now also offers the WriStable for sale directly, as they are the manufacturer. Most of all, you might want to be aware that on the BraceLab website, the clinician's classroom area offers you a wealth of clinical resources for therapists. So you might want to take a look there if you're unfamiliar. The problem we all face. What is causing the wrist pain? Wrist pain is very difficult to diagnose, as we all know, and that's based on the fact that there's complex anatomy. And everything we do, everything we load, everything we reach for crosses the wrist. And yet, the wrist, I think we all would agree, is not really built for weight bearing. It is impossible. Oh, pardon me. I'm unsure what happened there. Here we are. The complex anatomy absolutely prevents us from mechanically, manually evaluating any one specific ligament. Therefore, it's really difficult to precisely evaluate the wrist. And the pathodynamics and even just the basic kinesiology make it also difficult to know how these bones should be moving. Think about this. I often think about the carpal bones as, if you will, ball bearings. All of the wrist muscles cross over the wrist and insert distal to the carpal bones, with the one exception being the pisiform. And the pisiform is really superficial to the carpal bones, sort of not really a floating bone, if you will, but it's not really integral to the actual intercarpal movement. So here we have all of these ball bearings, the wrist bones, carpal bones, and yet the forces that cross the wrist don't really control them specifically. So no wonder we have a great deal of difficulty with controlling and specifically managing a specific area of pathology. Now, I think we all already know that the scapholunate ligament, the ligament between the scaphoid and the lunate, is the most vulnerable ligament, and it is most commonly injured when you fall on your wrist and you have axial loading with wrist extension. It's difficult to know what's wrong with the wrist. I think even very skilled clinicians are often in a quandary as to what is the specific problem. With traumatic injury, there are often multiple exams and lots of imaging that's done. And the other variable is that the person evaluating the wrist may not have the same level of expertise as another person. So the consistency of evaluation is lacking. Now, from the study done in 2020, it called evaluating a non-traumatic wrist a significant burden, in that it required a lot of investigation, follow-up, and treatment. And yet it's all fairly nebulous. It's at this stage still, at many times, ill-defined. But what do we know? We know that this wrist bearing weight depends at that end range more on the ligaments than the muscle. And yet, what we saw was that the ligaments are so complex that we can't be assured that the muscle is stabilizing anything. You can actually see on the dorsum of this wrist the attempted bowstringing of the extensor tendons. Whenever the wrist goes to its extreme motions, particularly into extension, the tendons do try to bowstring, but of course we have the retinaculum to prevent that. But the closer to the center of the axis of motion we can keep those tendons, the more we can prevent an overload to the tendons as well as to the carpal bones. When we do bear weight or when we fall, our radioscaphoid joint, meaning the radial side of our wrist, carries 50% of that axial load. So if we weigh 200 pounds, that's 100 pounds going directly through that radioscaphoid joint. And of course, the scapholigament, being the most commonly injured, is carrying part of that load on up through the carpus. I don't believe, are built for weight bearing. If someone does a push-up with their hands flat, as in this illustration on your right, illustration B, we are carrying 70% of our body weight across the wrist. Those small carpal bones and those even smaller ligaments are carrying a relatively large load. No wonder we often see problems resulting from this. Now, those who happen to be either elderly or they have natural wrist laxity are much more vulnerable to these intercarpal ligament injuries simply because they load them more. If someone is in a highly repetitive job, I mean, I can recall a mail sorter many years ago, you know, who all day long would throw the letter into the slots, and the wrist was in flexion and extension all day long. That also loads the ligaments, especially when you get to the end range of motion. So how do we as therapists, hand therapists, currently solve these wrist problems? Well, certainly there's been a significant amount of attention to learning how to do this, and most popular has become stabilization and proprioceptive exercises, which certainly has been proven to be effective. But we also have no way of really supporting the carpus other than immobilization. And during these different types of stabilization proprioceptive exercises, you need to have active wrist motion in order to learn how to control and limit the wrist range of motion. With immobilization, you cannot do that. In order to have a functional wrist, you need to have at least 70% of the normal range of motion of your wrist. This would translate into 40 degrees of wrist extension, 40 degrees of flexion, and 40 degrees each of radial and ulnar deviation. So it's a quandary. You really want to help your patient learn to stabilize and control their wrist, and yet maybe when they're doing heavy loading or when they're in an activity that they're vulnerable, you really want to protect them, but the only way to do that is to take away motion. So there's a real contradiction there in our ability to allow the patient to work on improving the proprioception and the stabilization and yet have protection. So the new solution, we think, is the WriStable. It not only gives you 70% of your motion, but it gets you to near end range. And it provides carpal support, and that carpal support is specific to the radial aspect of your wrist, which is your weight-bearing side. So let's look back kind of how this came to be developed. It started for me many, many years ago when I used to make a custom leather wristband that had a D-ring and a hook and loop closure. And I did this for patients who had sort of unexplained wrist pain, usually doing either highly repetitive or weight loading activities. And I found this extremely helpful. But I really couldn't figure out how to translate that into something that was marketable, because leather, as you know, it absorbs your body oils, and over time, it doesn't hold up to water. It just wasn't the right material. And yet, to put something around the wrist, it really needs to conform intimately and not constrict the blood and lymphatic flow. So that rolled around in my head for many years, and I kept thinking about it. And I kept going back to the fact that with this leather wristband on, if you look here on the left image, there is no strap in place. And this person who is weight bearing takes the wrist to 93 degrees of extension. But on the right, with the strap in place, weight bearing with the same amount of weight, this person only goes to 84 degrees. Certainly 70% of their normal range of motion. So I just kept thinking there has to be some way that this can be created. And then as I was kind of mulling this over, in 2019, I read an article in the Journal of Hand Therapy by Trevethik, Melfont, and Sayers. And it was an article about using a wrist brace with gymnasts. And there was this succinct sentence that just said, all gymnasts have wrist pain. And I thought, we're in the 21st century. Surely, as hand therapists, we can do something about this stated fact that all gymnasts have wrist pain. It was back to that same weight bearing, problem with pain, and carpal stabilization. Then, ironically, I developed my own idiopathic scapholunate instability, and which progressed to the point where I pop out, and believe me, that is extremely uncomfortable. So now I had a real motivation to think even more about how do you stabilize the radial side of the wrist. So what is the WriStable? How is this a solution? If I'm really honest, it really looks like nothing. It looks so small and so insignificant. It looks like a bracelet. How could it possibly stabilize anything? It doesn't really make immediate sense. And it is so different from any kind of wrist brace we have ever seen that we don't equate it with a wrist brace. It is a device that is constructed using a non-elastic strap that is relatively narrow, so it can fit beyond the distal radius and ulnar over the proximal carpal row. And that strap is infinitely adjustable. So it can be tightened by the wearer to the exact tightness required to allow the range of motion necessary and yet provide stability at the end range of that motion. Now, these two pads, if you will, these two pads are very simple in that they don't really block motion, but they serve other purposes that we're going to explain. The dorsal component is primarily to prevent constriction so that the blood and lymphatic flow is unimpeded in the hand. We have never had a report of a hand becoming edematous from wearing this strap. Now, a lot of people are very uneasy, assuming that that is what will happen and that such a narrow strap cannot be safely worn. But because of this molded component where there's no edge pressure, that is not the case. In addition to distributing pressure to allow the blood and lymphatic flow, it also distributes pressure, let's say when you're weight bearing and you're in full extension, rather than all of the force being focused on a narrow strap area, it makes it far more comfortable dorsally. I find, and others find, that a large function of this dorsal component also is proprioceptive input. I am so aware that the brace is on. I mean, it doesn't bother me. I wear one full time, but it reminds me. And oftentimes I think I'm not feeling any discomfort because I'm feeling the brace, which has, you know, it's neutral. It does not, in and of itself, that component, because it's a flexible component, it does not block the end range of motion. It flexes when you go to the end range of motion. The volar component is simply a location for a closure, which we needed, and we also did not want any kind of narrow strap going directly over the median nerve and compressing the nerve. So it really protects the median nerve from pressure. Both of these components are worn on the radial aspect of the wrist, because if we go back to the early slides where we talked about the weight bearing occurring on the radial carpal joint, which is the radial side, this brace needs to be on that side of the wrist in order to provide stability to the weight bearing joint. The strap also, because it's narrow, will fit in what I call a little groove. I mean, it's not really a groove, but it's a place. If you palpate and follow up your radial scapholunate, you slide your thumb up, your thumb will drop off into a little crevice. That's the anatomical snuff box. There is room for the strap there. The same is true just distal to the ulna, that there's room for a strap there. If the strap is not worn precisely in this location, this brace will not have any stabilizing value. Now, this non-elastic strap is fastened with a fastener that's called a cam buckle. It's this little lever you see with the arrow pointing to it. So you pull on the strap and then you push down on this lever and that locks the strap in place. I want to emphasize that the tightening of the strap is totally related to this cam buckle closure. There is an end of the strap as you go further around, and that is not adjusting the tension. We simply need some place for the end of the strap to rest so that it's not in the way, because the strap needs to slide and allow the brace to open up enough to put the size of the hand through it. But there is a trick to this that many people miss, and that is these little tabs to get in and out of this piece that locks it in. You have to tilt them to get them in or to get them out. We'll see that in a video in a moment. Now, the big question is, how on earth can something this small and this insignificant be effective? Well, think about your wrist and look at these measurements. In the middle is a neutral position of a wrist. The circumference is 16.3 centimeters. But either flexion or extension, radial deviation or ulnar deviation increases the circumference. So our wrist is smallest in its circumference, again, distal to the radius and ulna, when the wrist is a neutral. Therefore, it's logical that when you fasten the strap with the wrist in neutral and it's snug, as you attempt to go any direction, flexion, extension, radial, ulnar deviation, the strap then, if you will, becomes tighter because the wrist is trying to get larger, but the strap is non-elastic and it won't let it. So the irony is then, the more you go into an extreme emotion, the more support you have. I call this carpal containment. And I can't think of a really great analogy other than I'm sure some of you are old enough to have worn a girdle, the women, I assume. And, you know, if a girdle was really tight around someone's midsection, it's impossible to bend over. Everything, all the tissues are compressed and there's not enough room to move. So if we tighten the strap with the wrist in neutral, and as the wrist moves, the carpal bones are trying to move, but now that pressure that from externally is from all around circumferentially is tightening down. We are now containing those carpal bones and they cannot move as much. You can think of this simply as an external ligament, putting this strap on around the carpal bones. And yes, it prevents the absolute end range motion, but it does not prevent functional end range motion. So you can still weight bear, you can still do push-ups, you can carry a tray, you can do the things that require the end range motion, but technically you're not at the absolute end of motion. I think one of the major benefits of the WriStable is enhanced proprioception. You simply have this wonderful sense all the time of what your wrist is doing. We know that the skin is full of cutaneous mechanoreceptors, and the fact that that dorsal piece is over a larger area means that you very clearly have a sense of movement at all times. We also know that this heightens muscle activity, and both of those things together give you an increased sense of confidence. I will say to you that if I get up in the morning and I forget to put my WriStable on because I don't sleep in it, when I go into the kitchen and if I start to do something, loading my wrist, I'm immediately aware of it and I do feel a bit uneasy. I'm able to do it, but when I go and get the WriStable and put it on my wrist, I'm now very confident and secure that I can do whatever the task is. Let's say it's cutting something heavy, and know that I'm going to do that correctly and I'm not going to unduly load the ligaments of my wrist. This in turn provides, I find, significant pain control. I take the WriStable off and I have a dull ache in my wrist, and if I move it too far in any one direction, I do have something I would characterize as pain. So there's a lot of proof of this, and one of the studies I looked at in thinking through the rationale of the WriStable had to do with testing a soft knee brace, which I assume we all would think would not provide, quote, mechanical support, because it's not built mechanically stable. And yet in this test, the soft brace and the more structured brace were equal in their ability to provide stabilization, which is more from a muscle recruitment point of view than it was replacing the ligaments. So there's so much we don't know about how this external stimuli works. We all know that we use a lot of kinesiotaping now, and we know that that's helpful. So I think this is in many ways related to that. The best thing I think is that the WriStable does not in any way impede, and it actually enhances all of the approaches toward wrist rehab. You're not at all limited by having to, oh, well, I've overdone it, I need to put on an immobilizer. And as soon as you put on the immobilizer, then that takes away the input. It's hard to move forward if you're intermittently wearing an immobilizer. So I think that is, you can go ahead and do all of the exercises and all of the input with the brace in place. When would someone wear it? They would wear it anytime they're doing any activity that loads their wrist. Early on, we had an individual who complained of wrist pain golfing, not when he hit the ball, but when he came back way behind his head to get ready for the shot. That wrist extension was painful. There's so many different activities that require loading the wrist that can be made more comfortable by this carpal containment. I don't recommend for sleeping in it because it's constructed to alter the way the wrist is loaded, and you're not loading your wrist at night. I wear a night immobilization brace, and so for your patients that may also be indicated. Now, the WriStable comes in 4 sizes. The extra small size, which is a circumference of 4 to 5 inches, is intended for the youth. Those young gymnasts who still have skeletal immaturity can benefit greatly, I think, from wearing the WriStable as they're learning gymnastics. It's very important to realize that there is a right and a left to the WriStable. In order to be on the radial side, you absolutely must have the right or the left. If you try to switch them, it will not work in any way. And I want to emphasize again, you can have the WriStable, you can have the right size and side, but if you do not apply it correctly, you're not getting the benefits of it. So be sure you have the right or left, the right circumference side. When you put the WriStable on, you should be able to look down and read the word WriStable. If it's upside down, you have the brace on upside down. You tighten the strap to its maximum. It should be snug, but not too tight. You can always loosen it. And remember that that first closure, the cam buckle, is what controls the tightness. Then the remainder, as you bring it around, the tab closures, you must tilt those to insert and remove them. And if by chance you or a patient is wearing a WriStable in water, you should first wet the WriStable and retighten the strap because the strap does elongate slightly when wet. Now I'm going to play a video which had a script to it. This platform is unable to play audio from a video. So just for a moment, if you'll bear with me, I'm going to read the script so that the video is clearer. To experience the WriStable's full support, you must apply the brace correctly. Once you have the WriStable in the correct size, excuse me, I have audio playing in my ear, which you can't hear. There we go. Once you have the WriStable in your correct size, slip it over your wrist and open the closure tabs of the cam buckle. Slip the brace over your hand, ensuring the larger saddle shape is on the top of your wrist, and the smaller oval shape should be on the bottom of your wrist. The word WriStable should be right side up and easy to read. If not, you have it on incorrectly. Align the top of your brace with the radial side of your wrist between index and long fingers, and align and position the bottom on the palm of your hand. Keep your wrist in a neutral position while you tighten the strap, and then wrap the remaining strap around and fasten in with the tab closures. When you're certain you know how long the strap needs to be, you may cut off the excess tabs on the strap closure, but be careful that you leave 4 or 5 so that you have something to hold on to when removing the brace. Measure carefully. Once you cut, you cannot return the WriStable. Don't worry if you need to wear in the brace to become accustomed to it. It's like a new pair of shoes. And you may need to periodically reposition the WriStable as your skin underneath does move. If you need to move your wrist back a bit further to be able to perform a weight-bearing activity, you may wish to loosen the strap slightly. But you should still be able to feel the support of the brace. If you plan to wear the WriStable in water, first wet it and retighten as a wet strap elongates slightly. There are no limitations on how long you can wear or should wear the WriStable. You can wear it as much as you want or need. If you prefer, you can wear it only during the activities that cause you wrist pain. Okay, the one thing that I would like to add to that is that my wrist, because it's undergoing continued changes, and I'll explain that a bit more, varies in size. One day I might have 5 tabs extra after I close it, and some days I have 1. So do allow some time for your patient to wear the brace before you decide how long the how long the strap should be. Some patients would have the exact same wrist size all the time because they don't really have enough wrist pathology. But you need time to determine that. Now, when is the WriStable indicated? Well, I would love to say anytime there's wrist pain. Mainly because I don't see how this could do any harm. It simply reloads the wrist, and that tells you whether or not it's helpful. It is particularly helpful with scapholunate instability, as we've discussed, and it's also really helpful anytime you have a young athlete who risks dorsal abutment or impingement of the wrist. That's why we made the smaller size for the younger set. You can read this list as well as I can. I would make one comment about the wrist arthritis, and that is that no, the WriStable is not going to cure or alleviate wrist arthritis. But because it changes the load of the wrist, even in the presence of significant arthritis, the WriStable may be helpful in diminishing pain and thereby increasing function. We've also found it helpful with patients following a distal radius fracture. It's very hard to have a distal radius fracture and not have some associated, at least strain of the carpal ligaments. And it is not designed for ulnar-sided pain, but because there is a strap distal to the ulna, I personally found it a significant relief for ulnar-sided wrist pain. Not quite sure that that was TFCC because I have kind of multi-problems. And I'm sure there are many other things we will be able to add to this list over time as we have additional patients using it for a variety of reasons. So who would you think about using the WriStable for? Well, I would say almost anyone. This photo in the bottom right is a grandmother lifting her grandchild who couldn't do this without the WriStable in place. So anytime there's any loading of the wrist, but it is especially useful for those who load it heavily with their weight, gymnasts, cheerleaders, everybody who does push-ups or yoga or any kind of racket sports, yard work. And I think it has a role with anyone with scapholunate instability, whether they are pre or post-operative, or they may even be non-operative. I myself, having worn this all day, every day, I now have a very stable scapholunate joint. I have some other issues, but I don't have scapholunate. Maybe you just want to limit the end range during the rehab. Maybe there's some other reason you want to control the load on the wrist. When would you not use it? I would not use it if there is an open wound at or near the wrist. There's, I think, too much friction, too much load. I would not use it in the presence of an already acutely edematous hand or wrist. It does not cause edema of the hand, but I don't think it would be wise to apply. I would also be very cautious if the individual has, if they have had or they have carpal tunnel syndrome, because you don't really want to risk any additional pressure in that area. Caring for the wristable is really simple. You take a lingerie bag, place the wristable inside, throw it in the washing machine, you know, maybe not too hot, delicate cycle, and just dry it by the air. I often rinse mine out by hand and it air dries on its own. Sometimes I swim with it and I forget to dry it and it dries in place. What you do not want to do is to use bleach or wash it and dry it in the dishwasher, because that's just too hot and too, the soap is really abrasive. And don't use a solvent or a harsh chemical on the wristable. Now, what is the evidence? Well, I'm offering my own personal experience as evidence. Here is the x-ray of my right wrist in February of 2020, and you can see the gap between my scaphoid and my lunate, and that is when I began wearing the wristable. In December 2023, I now have intracarpal arthritis. I do have a stable scapholunate joint. But during this entire time, I have worn the wristable full time, and I'm able to do almost everything I want to do, with the exception, obviously, of heavy loading, heavy resistive activities, which would simply be unwise with this pathology in my wrist. I do not attempt to weight bear. I probably could, but I don't think it's wise for me to do so. I do use it all day throughout the day. I get it wet, I garden with it. And as I mentioned previously, however, I do not sleep in it. Now, we did complete a field study, but keep in mind the field study is not testing whether or not the wristable works. It is testing the product, and does the product work? Are there any issues with it? Does it function as it should under typical wear? We had all sorts of volunteers who tried out the wristable, and the conclusion was there were no changes needed to the product at all. It was comfortable, it was convenient, they were able to put it on and take it off accurately. So we then, following this field study, released the wristable. But let me give you just a few brief histories. Brian had pain with push-ups because he had 2 previous forearm fractures in the same arm when he was 11 and 13 years old. And he asked after the end of the field study whether he could keep his wristable, because that's the only way he could comfortably do push-ups. So he has been wearing it since March of 2023. He's an individual who always wears it in the exact same tension. It does not vary with him because he doesn't really have wrist pathology. He has probably a forearm, the forearm healing of the bones probably has altered the load of his wrist. So we have found with all the patients who have purchased the wristable since it's been introduced almost 2 years ago, is that they have a very positive response to using it if it's used as indicated. If they try to use it for a diagnosis for which it's not indicated, then obviously they are not going to be satisfied. Another example is John, who is a 73-year-old mechanic who eats, sleeps, and breathes mechanics. Severe wrist arthritis from rheumatoid arthritis. He was able, with the wristable on, to manage hand tools and take apart small parts which he could not tolerate doing without the WriStable in place. And interestingly, when we did our 3-hour photo shoot with 2 young gymnasts who had no wrist pain, each of them separately after the photo session asked if they could keep one because the wrist on which they wore the WriStable felt so much better than the one without. I guess gymnasts assume that wrist pain is part of being a gymnast. I don't think it has to be that way. Hunter was the professional photographer who did our product photo shoot, and he complained of pain at the end of the day of a shoot because he had to put together all this equipment and take it all apart and carry it in and out. He now wears the WriStable during photo shoots and has no pain at the end of the day. So the bottom line is that I think there are a lot of individuals out there who have some wrist pain with what they're doing. Let's take yoga as an example. And they assume it is a necessary part of yoga. With the WriStable, I do not think that any longer needs to be a true statement. I think now they can be pain-free and protect the wrist while they're doing the activity. Now, I've done a lot of talking, and we are ready for questions. Carrie has been looking at the questions, and she's going to read those off. But while we're discussing the questions, feel free to take your phone and scan this QR code and request a free sample for yourself or for a patient. And you will need to request right or left and the size. So you might want to wait, come back to the video recording to request this so that if you have a specific patient in mind, you can have the accurate measurement. So Carrie, what are the questions?
We have a question, when to choose this versus a wrist widget?
Well, a wrist widget, in my understanding, is specifically designed for ulnar-sided wrist pain, and more specifically TFCC problems. So I would follow that and make it simply that if it's a radial-sided wrist pain, weight-bearing, loading, pain on the radial side, I would choose the WriStable. I would choose a wrist widget if it's on the ulnar side, which just seems very logical.
Okay, thank you. Is weight bearing your primary symptom to indicate a trial of a WriStable splint?
No, I don't think so, because you know, take golf, for example, or take a racket sport where your wrist is going way into the extreme and then back down, but it's still being loaded. I simply think any kind of loading of the wrist, and particularly loading into the extremes of motion, and that the most common, obviously, is extension. But because the wrist, I don't think is built for weight bearing, and because that it's often a heavier load, then the weight bearing often is kind of a more, it's a stronger indicator, I would say. Hope I answered that.
Okay, how does this work for decor veins?
Well, that's a good question, and the answer is I absolutely don't know. Several people, as we were developing this, were concerned that it would create decor veins. That is absolutely not the case. We have had no reports of that at all. I would say, decor veins is it's a restriction of the ability of the tendon to go through the retinaculum. And if there's bowstringing, perhaps pressure would help. But because there's already synovitis and it's already difficult, I'm not sure pressure would help. If I had a patient with decor veins tomorrow, I might try it. Just try it on them to see what their reaction was. And I'd love to hear if anybody does that. You know, the irony is that I started my retirement just as the WriStable was released. So I don't personally have as much direct clinical information as I might have otherwise. Don't let me know. I'd love to know. It's a great question.
Okay, we have another question. Can the WriStable effectively help a slack wrist?
I'm again going to say I don't know, because, and the reason I'm saying I don't know is because, you know, I don't have any imaging that would prove it one way or the other. My comment would be, however, that all wrist problems, including the slack wrist, are painful when loaded. And if the WriStable changes the loading, limits the range, decreases the carpal stress, if you will, then yes, perhaps it can be helpful symptomatically. It's not going to cure the slack wrist. It's not going to change it. But perhaps someone might find it more functional. Again, I don't know. I think I would love, again, for someone to look at this specifically and let us know.
Another question we have is, how soon after SL ligament reconstruction can you use the WriStable?
Well, my feeling is you want any wound that's underneath it to be healing or healed. The problem is if you put a bandage underneath the WriStable, you're adding padding, and padding loses some of the stabilizing ability of the WriStable. So you're diluting the ability of the WriStable. I would say it's individual, and you know, it depends on the wound healing. What I might do is I might put something just over the wound, extremely thin, to prevent abrasion, if you will. I mean, it's not true abrasion, but prevent the WriStable from moving on the newly healed tissue, if you follow me, directly. But I would not pad it. Does that make sense?
I think those are great ideas. We have another question. Can the WriStable help prevent lateral epicondylitis, given it can be attributed to repetitive wrist motion?
I would again say I do not know. But what I would say is you're not taking anything away from the individual who's wearing a WriStable. They still have almost full range of motion. And so I cannot imagine it would be contraindicated in any way, and maybe well worth trying. There are a lot of unknowns yet to how it would influence associated problems, that being a good example. It is still a new product.
And another question is, can the WriStable help patients with Ehlers-Danlos syndrome?
I would say yes and no. As you all know, when you stabilize one area in a patient who has hypermobility, you then load the adjacent areas even more. And Ehlers-Danlos is the extreme of hypermobility. So you might gain some wrist stability in the radiocarpal joint, but then perhaps that shifts the instability more to other areas that are undesirable. You know, I truly don't know. I don't have an absolute answer. If I was faced with that situation, I would probably try it with the individual from the point of view of simply wanting to help the person functionally. But I would be acutely aware of the possibility of creating problems in other areas, and I would monitor that closely.
Great. Some of the pictures, someone commented that the splint looks more radially positioned, and some of the pictures are more dorsal radially. Can you talk more about this position? I think I noticed that with the, I think I noticed that with the saw.
Okay, I'm a little confused. Can you repeat that?
Okay. Some of the pictures, the splint looks more radially, and some more dorsal. The question is dorsal radially. Can you talk more about the position? I think I kind of see what that this question is relating to. There was a picture using the saw, and it looked like it was
going back to try to find the saw.
I believe that's what this question might be.
There?
Yes, like it looks a little bit more radial. That's what I noticed.
Well, I think perhaps you're right on that. You know, I think that has either it's been put on a little bit. I mean, you know, I wasn't there during the photo shoot, so yeah. But the ideal position where you want it is, here's a good example on this image. Look at the second and third metacarpals and their bases. That's the stability of the hand related to the carpal bones, and that's directly below, directly above the radius. So this is the ideal posture. I also think the other one is kind of how it was turned, and it looks a little bit more radial than it might be, but did that answer it?
I think so. That was really great. The second and third metacarpal explaining the position, but I do believe you said earlier that you can change the position and figure out the most comfortable position for you. So that makes sense.
Well, you don't change the position of it. You don't change it from the radial to the ulnar side. What you do is the dorsal skin is so incredibly mobile that it moves with the skin a little bit over time, over the day. And periodically, you may have to open it up and scoot it back out distally and then fasten it back down. Do you follow me?
Yes, thank you for that clarification. I think that was very helpful.
I would go back to the last slide just in case people are still looking for the QR code. Okay.
This has been a great webinar today. Thank you so much for offering such great explanation and information about this really helpful splint. Thank you.
Well, I hope it is. It's not the answer for everything, but when you release a product, you're not always sure. You can't be sure the extent to which it might or might not be helpful. So what you need to do is gather data over time as people use it, and when there's consistent response that yes, it's useful for this, no, it's not for this. And BraceLab does endeavor to present that accurately. We're not trying to provide this for everything under the sun. But I also think there are lots of times when it's a very subtle problem, people don't realize it's a problem, and it can become a problem. So I do think there are a lot of niches where it could be of great use.
There was a question, is there an insurance code for this?
There is not, and the single reason that the agency that assigns L code look upon this as a strap. And straps, as you know, like your elbow straps, are never covered under reimbursement codes.
Wait, can you hear me? This is Olive from BraceLab.
Yes.
We actually do have an L code. We got one recently. So we can share that if anybody is interested. I do not have the exact L code on me, but we do have something now.
I was unaware of that. I do apologize. That comes from being retired.
It's very recent, but this is what I'm here for, to provide that update.
Good, good. Carrie, are there any more questions?
No, I think this is about, yeah, this is wonderful. We're ending right on time, and this has been a great wealth of information. I appreciate that. Thank you.
You're most welcome. Wish I could have seen everybody. Thanks so much. Bye.
Thank you. Good night.